How about cases of cortical breakthrough? For example, I was reading a study today with anterior cortical breakthrough, and so that bone interface is gone on that part. Is that still ablating the anterior portion of the tumor? Is that something that is important to the process?
At that point, if it's gone through the bone in that area, there probably is not much nerve tissue left to be bringing pain back. You just want to find the interface between the tumor and the bone and burn there. Now, a key point with that is when you're cementing, you want to put the cement in good bone first and then over into whatever tumor you're going into. That's the ideal. It obviously doesn't happen that way all the time, because if the vertebral body is gone, then where's the good bone to put cement into? It's not there. But the ideal is if you've got a vertebral body and the left side of it is eaten up and the right side is normal, put your cement in the right side first and then cement over into the left side.
That's a great point. So how do you approach that? So most of these cases, or all these cases perhaps, are bipedicular access, I'm assuming?
Yeah, all these cases are bipedicular access. The reason being that shapes the burn to be roughly the shape of the vertebral body. So there's some crosstalk between the RFA probes. Now, this is something that I caught on to a little while back and finally understood, but I've asked people, do you know how radiofrequency ablation works? And they say, yeah, it heats up the tissue. I said, well, yeah, but how does it work? I don't know, it gets hot? No, that's not how it happens. Basically, you've got two, and I ask them, what do you know about electricity? And they say, you plug it into the wall and it turns on. But you have a positive charge and a negative charge. Anything that is positively charged will go toward the negative pole. Anything that is negatively charged will go toward the positive pole. So if you generate a charge between those two things, you're going to move charged particles between them. Then if you switch the polarity, they'll make a quick U-turn and move back. And then you switch the polarity again, they make a quick U-turn and move back. And it's those charged particles moving back and forth at the frequency, which is the same frequency as a radio wave, that generates the heat. It's the moving particles is kinetic energy, and it generates heat. It's not the probe getting hot. It's the probe inducing heat in the area around it by causing charged particles to vibrate. Now, the device that I use at OsteoCool, people say, what's the cool part of it? Well, what they do is they pump water down through the probe to carry away the heat from the surface of the probe. The reason that's important is because if it gets too hot, you will form charcoal around the probe. And charcoal is a really good insulator, so you can't get an electric field past it. So the reason why you have these cooled RFA systems is to increase the size of the burn, because it takes away some of the heat right around the probe and keeps it from charring.
It's a really great point. And I think anyone who's spent a little time in the operating room, whether intern year or med school or beyond that, you just think about a BOVI, radiofrequency ablation device, basically. Well, that starts to get some char on there, it really stops working. And so that's why you have the scratch pad and do that kind of stuff. So these kind of cooled radiofrequency is it's kind of like a scratch pad without the need for it. Keeps that char from forming, so you get a better ablation zone, and you don't run into those issues with impedance. And we call it peding out, where the generator the impedance, you just see it climbing. You're like, nope, it's gonna go out. And I haven't run into that issue using these devices.
No, using the cooled devices, I have rare as hen's teeth for it to impede out. It just kind of sits and chugs for a while, and you tell your dad jokes, and off you go.
Yeah. That's the process. That's how you have to do it. Before I forget, can you tell a little bit about the technicality of the pedicle burn? Are you doing a full length burn as the same duration, or no?
No, and there's actually a different setting on the device. You have the cooled device setting, and then you've actually got retract mode. And when you put it into retract mode, it just does a radiofrequency burn. And they actually have a table telling you how long you burn in order to make a burn of a certain size. So when you are dealing with a pedicle, number one, you do not want to burn both pedicles at the same time. because remember, there's crosstalk between those two
that's a good
RFA
point.
probes, and there's stuff in between the pedicles that you do not want to heat up.
Don't cross the streams, bro.
No, don't cross the streams. It's like Ghostbusters. So you want to make sure that you are only doing one at a time if you're doing this retract mode. Let's see. I think that's all for the pre-procedure planning. It's pretty straightforward. So if you know how to get into a vertebral body, you basically know what you're supposed to do. There is one point. The device that you use, the needle that you use to put in, they have a particular trocar that goes down through the cannula, and the tip of that trocar marks the posterior aspect of the burr. So when you put the trocars in, you want to make sure that that tip is just beyond the posterior wall of the vertebral body. And you know that that's as far back as the burn is going to go.
And the cortex, as we know.
That's easier to see on one of the images that I'll show you here later, is where that is. But yeah, the cortex has a lot of nerves in it, and you can paradoxically increase their pain by burning the nerves of their posterior cortex.
That's a good pearl to know. Cortex it's a good insulator sometimes, and then you don't always have that, and so you can kind of think of, well, usually the epidural space and the thecal space, if that posterior cortex is intact, you have a nice insulation effect against the heat spreading out too much.
You'd like to think that.
You'd like to think, but it can happen, as we've talked about. And so tell us about, I was kind of thinking towards, the obvious example of the posterior cortex being partly eaten away by the tumor. But you've told me about a situation where even with a normal cortex, you can have some issues happen. So kind of pearls on that.
Pearls on that are the thecal sac. If you think about it, the nerves are going to follow gravity inside the thecal sac. So they fall down and they're resting right against the back of the vertebral body when you have the patient prone. So if you heat up that posterior aspect, you can get a neuropraxia from heating up those nerves. And that is a very unpleasant thing to try to explain to a patient.
That's good to know, and something that probably should be part of the informed consent process, just about
Absolutely.
things
It should be
aware
Absolutely.
of.
You always talk about bleeding and infection, but in this case, you also say, and there's a lot of nerves running by there that we don't want to hit, which is why we're going to use X-ray to make sure that our needle's going into the right spot. Despite our best efforts, sometimes those nerves are going to be injured while we're doing this. I will do everything I can to keep that from happening, and if they do get injured by heat, they'll probably get better, but it's going to take a while. It's going to take several months.